Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Welcome to the Egg Whisperer Show. I am beyond excited to have Dr. Sher back on to talk about a very important topic, why you need to do PGT testing if you're doing IVF. Or do you? Dr. Sher, welcome back to the show.
It's a pleasure to be with you, Amy. Thank you.
I want to dive deep into this topic, but before I start talking, for those listeners who don't know who you are, they really should. I just want to tell everyone a little bit more about you. You're co-founder of Sher Fertility Solutions, internationally renowned expert in the field of ART, which stands for Assisted Reproductive Technology, and influential in the births of over 17,000 IVF babies. Over the last 30 years, you've helped fashion the entire field of ART. You trained under the fathers of IVF, Doctors Patrick Steptoe and Robert Edwards. Dr. Sher established the first private IVF program in the US in 1982. And Dr. Sher, isn't there something pretty important that you've done related to PGT as well?
Amy, let me just say this. Until the end of the century, and even at the first few years of this century, people were still using a method for testing human embryos known as fluorescence in situ hybridization, or FISH, where you could only isolate certain chromosomes, not all of them. And so we weren't able to use FISH to tell if an embryo had all 46 chromosomes. We could look at the most important ones, but largely those ones which, when they were abnormal, resulted in miscarriages, losses in that area. But it wasn't good enough. And so it was that I became very interested in a new technology that evolved for evaluating for the presence of all the chromosomes, and was a new technology known as CGH. And what we did is we started to look at embryos, taking a few cells from them, and then biopsying those embryos from the surface of the blastocyst, and then looking at all the chromosomes to see if they were all present. And in 2005, I think it was, we published the very first paper that showed, beyond a shadow of a doubt, that if you were able to fully karyotype the embryo cells, in other words, know that all 46 chromosomes are present, that embryo would have an excellent chance of taking. And with that, I wrote the first paper on chromosomal analysis, full karyotyping of embryos. It gained traction. And I got a phone call from a guy in New York who was in the genetics field, and a good friend of mine. He said, "What the heck are you doing? We're doing FISH, and you coming up with this new idea. It's throwing us in a tiz. I want to come to your clinic and see what you're doing." We'd already established a genetics laboratory that did the testing of the cells of the embryo. So they came here, they saw it, and they were impressed enough to ask me if we could share it with them, which I did, because it wasn't morally acceptable to hold on to technology that could help people simply for there being some other financial benefit. So we handed it over to them, and they dispersed it all over the world. So today there's hardly an IVF program in the world that is not doing PGT or PGS on embryos in cases where it's needed. So with that background, that's how we launched it. And then in 2005 or 2006, we expanded that technology to biopsying the egg, because outside on the surface of the egg, there's a little extrusion of genetic material called a polar body. We actually tested that, and I sent it off to Robert Edwards, the paper we published. He published it in his journal, RBM Online, and it was, I think, one of the last papers that he published himself, that he promoted himself before he sadly and tragically passed away. But that's how it came into being. And now today, the problem is that the pendulum has gone too far. Now PGT or PGS is viewed as being something that everybody needs. They don't. in my opinion.
And why?
Well, firstly, let's understand that as a woman gets older, the eggs that are in her ovaries decrease in number as she uses them up. And also, not only that, at a certain point when the number falls below a certain theoretical threshold, then she has too few eggs in her ovaries to ensure reproductive security. And that's when she goes into diminished ovarian reserve, and we can pick that up by doing certain tests on her blood, including most recently the introduction of anti-Müllerian hormone or AMH. But separate from the issue of reducing the egg number, which makes fewer eggs available in any given cycle, there's the other aspect to it, and that is that invariably as a woman gets older, regardless of her ovarian reserve or how many eggs she's got left, the quality of the eggs declines through wear and tear, because those are the only eggs she's ever going to have. And at a certain age, the integrity of the egg is compromised as a consequence of that wear and tear effect. So women over the age of 35 will start seeing a decline in the integrity of their eggs, and it's the egg and not the sperm that is most important in propagating a viable chromosomally normal embryo. So in women under 35, roughly 2 in 3 eggs are normal. So you're likely to get most of the eggs that you get making embryos that are normal, unless there's a very severe male factor or something else that you come across. So clearly age is a cutoff. After 35, there's a decline. So at the age of 40, maybe 1 in 5 is normal. At the age of 42, maybe 1 in 8 or 10 is normal. And at the age of 45, maybe 1 in 20 to 25 are normal. So there's a decline in the integrity of the egg. There's a decline in the number of eggs. And together we refer to those two collectively as the biological clock. They advance over time. And there's nothing we can do, nothing known to man, that can enhance and improve the chromosomal integrity of eggs that have been in the woman's body all her age, except that if she goes through ovarian stimulation for IVF and you don't use the right protocol to stimulate her, you can create a hormonal environment in the ovary that can further compromise the eggs. So with this backdrop, I believe that women who are young, where 2 in 3 eggs are normal, up to the age of 35, and where the cause of infertility is pretty clear-cut, tubes are blocked, there's nothing wrong with their uterus, and the man is fertile, do not require routine PGT and PGS. I reserve that for women that are older, and now there's an increased likelihood that the egg quality and therefore the embryo chromosomal integrity will be reduced, and for women that have diminished ovarian reserve, because if they've got, regardless of their age, because if they've got diminished ovarian reserve, this will also impact upon the egg's chromosomal integrity as it goes through maturational division. And I also believe that if there's a history of repeated pregnancy loss, recurrent IVF failure, or unexplained infertility, knowing how vital the egg's role is in propagating that viable pregnancy, in those patients I will probably also recommend doing PGS, PGT.
There are some people who might have a chromosomal disorder, something that they basically inherited at birth. How do you rule that out before
That's really an important point, which I omitted to mention. There are certain situations where there are chromosomal abnormalities, or there are genetic abnormalities that we know can be perpetuated and are linked to a chromosomal abnormality. In such cases, we would also do testing. But those aren't that common, as you know. They're far less important. But clearly, if there's something genetic that you want to test in an embryo, you would need to look at the gene sequence on the chromosomes of that embryo. But at the same time as doing that, you would also have access to the embryo to do PGT for chromosomal integrity, counting the number of chromosomes present.
If a patient says to you, Dr. Sher, I don't want to do PGT because I don't want my embryos to be harmed, how would you reply to that? Or how would you address her concerns?
I don't know, there are people that will disagree with me, but we have done hundreds and hundreds of cases before we published on the impact. And we actually looked at the egg. We did the biopsy of the polar body after fertilization. We biopsied the embryo. Then we biopsied the blastocyst. And we've been able to show, to my satisfaction, that if done correctly, PGT, the biopsy, will not compromise the embryo. It's another thing if you biopsy an egg. An egg is a single cell. A lot can go wrong. But an embryo that we biopsy is over 100 cells. It's a blastocyst. And therefore, if you biopsy it expertly and you've got good people who can do it, you're not going to compromise the embryo. What I think is wrong, for reasons that I'll just try to explain very briefly, is to take an embryo that's been frozen, thaw it, biopsy it, refreeze it in order to have it ready for transfer at a later stage, then have to rethaw it for transferring it. I know, and we've also had pregnancies that have occurred with such secondary PGT, where you do it on an embryo that's already been frozen. But I'm convinced in my mind that this is traumatic on the embryo. On the other hand, if you freeze an embryo when it's only just fertilized as a 2PN, or if you freeze it on day 3 when it's got a few more days to go before it reaches blastocyst, and you then thaw it to allow it to go to blastocyst and biopsy it, you're not doing any harm because the embryo recovers by the time it reaches blastocyst. I'm just saying it's not a good idea to take blastocysts that are already established and frozen unless you absolutely have an imperative to do so and rebiopsy them for future use. Because after all, the biopsy of the embryo doesn't make a better embryo. It's simply selecting the best ones to put back.
Could definitely harm an embryo. And I've seen patients come to me where they had morulas biopsied or early blastocyst biopsies, and my eyes just jump out of my head and I get inside. You can probably tell I'm a little bit passionate about this topic. I get so furious that in that type of situation, they could definitely destroy an embryo for somebody. So I always say, if a doctor is saying to you, don't do PGT because it might destroy your embryo, you really want to question doing PGT there. And so I have the same response as you. I mean, here, embryo biopsy is done so expertly. I feel very confident that we are not compromising an embryo because we really choose our embryos wisely before we even do the biopsy.
Well, I agree 100% with you on this. You shouldn't be biopsying morally, and I don't believe you should be biopsying earlier embryos than that. And an embryo deserves the opportunity to get to the expanded blastocyst stage with lots of fluid inside and distended by no later than day 6. Trying to do this 7 days after you fertilize the egg, in my opinion, is also a travesty because the pregnancy rate is virtually zero when you use embryos. You will report 1 or 2 cases here and there, but the truth is, I don't believe in day 7 blastocysts being biopsied.
I've been pretty lucky and fortunate. I mean, I think sometimes when your retrieval's after 12:30, for example, and your ICSI's much later, and those types of circumstances, I think.
I'm sure there are exceptions to the rule, but as a general rule, you want to get an embryo biopsied by day 5 or 6. I agree with you. You need the expertise. Our people have been doing these biopsies for 20 years. So your people are also expert, so they're not going to make... Our program in New York is still manned by the people that did the original, some of the people that did the original research with us, that launched PGT into the field. So from my perspective, everything is expertise, and it's not something you can teach someone from a book, just like you can't teach someone to be a good IVF doctor by following a recipe in a textbook. You have to have done it over and over, made lots of mistakes, learned from them, and be better for them.
And why do you think there's so much criticism about it? Do you think it has to do with how expensive it is? What do you think the issues are related to why it's so controversial?
Well, first of all, I agree that there's a group of women that don't need it that are being done. I would criticize that as well. But why is it controversial? I think it's because of the fact that many doctors go to their patients and they say, look, we did PGT, it was a beautiful blastocyst, it was normal, but you didn't get pregnant. Therefore, it's got to be something wrong with the PGT that was done, ignoring the many other factors which we spoke about in a previous discussion, where it involves implantation, and they haven't looked into the reasons why that embryo might not have taken, and they haven't looked into all of the aspects. And again, there's another very important factor. that people often ignore. Embryo transfer is a very precise, delicate procedure. You can't just teach someone to do embryo transfer by saying, do what I do. They've got to do it and do it over and over. And the REs that I've trained them to do embryo transfers in IUI cycles. So they get familiar and used to tracking the course of the cervix and doing it all under ultrasound guidance. So I think there's a big problem with expertise. So if doctors are going to use it as an excuse as to why pregnancy didn't occur, I think that's plain ignorant, because there's so many other possible reasons, including technical failure and including simply the fact that they've missed other obvious causes of implantation failure along the line.
Real quick, we could have a whole interview just about this. What do you tell patients about their mosaic embryos, or the possibility that their abnormals could really be normal when they share those concerns with you?
Let me tell you how mosaicism was born. We had a procedure we were offering our patients, which I still offer, called hindsight PGT. Hindsight, which meant people would come for IVF, they didn't want to spend the money, they didn't want to get involved in the cost, but they wanted to know if the pregnancy didn't take, why didn't it take? Was it something wrong with the embryo? Or they want to know why they miscarried when they got pregnant. So we do the biopsy of the embryo, we freeze the DNA of the cells, and we keep it and hold it. We put the embryos back after the biopsy fresh in that same cycle. If the woman doesn't get pregnant, or she gets pregnant and loses it, or if for any reason once she's pregnant, she wants reassurance that that embryo is a normal one, she'll come back to us at her discretion and say, look, could you please do PGT on this embryo? We'll send away the DNA, they'll amplify it, they'll develop the test, do the test, and then they'll give us a result. Doing this in large numbers of patients, we were able to define a group of patients who had babies that were healthy and normal, but when we looked back at the DNA, that the cells, they were normal.
You mean the cells were mosaic when you looked back?
No, what I'm saying is that, we said to ourselves, if it was abnormal before, but the baby was born normal, there needed to be cells that converted to normality in the uterus. It was either that or the test was faulty. Now, we know that the faulty rate is 3 to 5% in any test you do, but not at the level that we saw. I've seen probably close to 20 women who've given birth to healthy babies with abnormal embryos that we determined from the hindsight PGT study we did. So with that information at hand, I said to myself, there's got to, and I had a discussion with other people in the field, and the term mosaicism was used to explain that if some of the cells were abnormal that we tested, that embryo must have been basically normal with some abnormal cells that could be rescued and overwhelmed by the normal ones in the uterus. So that's how the term mosaicism came up, patchwork. And it's a real entity. But you can't use mosaicism in older women, because the older a woman gets, the greater the likelihood is that the embryo is abnormal, not because something happened to a normal embryo making abnormal cells after it's fertilized, but because the egg was defective, which we call meiotic aneuploidy. It happened in the egg, not in a fertilized egg that was normal, and some of the cells became abnormal through mitotic replication of cells. And because of that, the older a woman becomes, if there's an abnormality, the far less likely. If only 1 in 20 cells in a woman of 45 is going to be normal, what if only 1 out of 20 is going to be chromosomally normal? Those are the odds to start with, that the embryo that you are biopsying, that you're calling potentially mosaic, was actually truly a normal embryo when it fertilized, which it had to be mosaic. In a younger woman where 2 in 3 are normal and you get an abnormal one, now your odds are much, much greater that if you get the same chromosomal abnormality, it could be due to mosaicism. So mosaicism is something to be considered, especially in the younger woman who you're doing PGT on and where it's abnormal. And no matter what they tell you, the tests that are out there in the laboratories for mosaicism are largely hit and miss. I mean, they get you closer to it, but they don't tell you for sure. So the women that I would say should be given the opportunity of using embryos that are chromosomally abnormal are younger women with single or at the most 2 chromosomes aneuploid in the embryo, and preferably not the sex chromosomes. And if it's going to be 2 chromosome pairs that are affected, I'd much prefer to see it be those that don't cause birth defects, like trisomy 21, trisomy 18, etc. It's usually going to be those in the lower range where it's less likely to get abnormalities, and usually women where there's 1 chromosome missing rather than 1 chromosome extra, because those where there's 1 chromosome missing or monosomies very rarely, if ever, are going to result in the birth of a child. The woman will either not get pregnant or miscarry.
And I find it extremely frustrating, and that's why it's so important for us to talk about this over and over, is doctors aren't making those calls to patients about their genetic reports anymore because everyone is just so busy. So patients are just getting a phone call. They're being told, your embryos are abnormal, click, the embryos are getting discarded, and there's no follow-up. Patients aren't getting their actual reports. And so if you're listening to Jeff and I talking today, you're obviously interested in PGT or you've already gone through it. It is so important for you to actually get your official reports. Do a post-IVF consult with your fertility doctor, with the genetic counselor affiliated with the genetic testing company. Your embryos deserve that. They deserve a chance. If there is a chance for them to be a viable embryo, find that out before they're discarded. You don't want to find out after the fact that you could have discarded a perfectly healthy embryo that was mosaic and could have turned into a healthy blast for you. So it's so important. And I know what you and I are saying, we're probably about 5 years ahead of folks, and other people will finally be catching on. But I know there's a movement for transparency, for fertility clinics to share with their patients up front what their reporting practices are for mosaicism and what their transfer practices are ahead of time, but it's still not happening yet. So I'm so glad that you talked about this today.
You and I are absolutely on the same page. I have a consultation with every one of my patients once the results come in to discuss the meaning of it. And when I go through the consultation and recommend PGT, we have this conversation as well. Look, it's back to the old concept. You can teach people to give care, you can't teach people to care.
So true. Well, Jeff, thank you again for coming back on. I would love to talk to you more. Have you come on again? I want to talk about endometriosis. I'd love to talk to you about OHSS and how you approach that diagnosis. Will you do that another time?
Be more than happy to. I love talking to you.
Thank you. Can you just share with our listeners where they can find you should they want to do a consult with you?
Again, as I mentioned in a previous discussion we had, I feel badly because I'm not trying to solicit people, but those who think they need my advice, or people refer to me, and I get many referrals from other doctors who aren't arrogant about the fact that there are areas in all of our portfolios where we lack perhaps a little bit of expertise, or they want a little bit of endorsement of their opinions, then I'm more than happy to talk to people. Now, I practice in New York. I don't practice on the West Coast. My clinic is on 5th Avenue and 38th Street in New York. So people who are interested in my treatment, I'll be very happy to talk to, but even if they're not, I'm more than happy to talk to them and refer them back to their referring doctor. So the way to reach me is to contact my assistant. Her name is Patty Converse. Patty Converse, 702-533-2691, or email her at concierge, CONCIERGE, at sherivf.com, and have her reach out to you and set you up with an online consultation with me. We'll go over all your records, discuss your case. I generate a report which you can do with what you wish. But I will do that for you and be more than happy to talk to you.
Wonderful. Thank you, Jeff. Thank you for being so generous with your time. Thank you for just being such a light out there for all of us. I have to tell you, my patients who are coming in and they've listened to your podcast, the feedback has just been so tremendous. The things that you say really resonate with them and they really feel heard. So I know if my patients are saying that, you can imagine that listeners all over the world feel the same way.
Thank you. Very gracious.
Of course. Have a great day. We'll see you soon.